I'm going to talk about another drug we talked about, that study. It's probably the only drug that has been studied in many randomized controlled trials. So most of you are familiar with it. I'm just going to give an update. There are some controversies on how to use the patent, when to use the patent, should we use prophylaxis in all babies, or should we intubate, keep them intubated. So I'm briefly going to touch on this subject. There are two more speakers that are going to follow me. I'm going to only, in my part, I'm going to skip some slides, show you comparative data, the difference of factors that are available for us to use. I'm showing this tiny baby. This is the baby now. Okay. I never thought this baby was going to survive the development unit. Now for 330 days, that's what the baby is. September 11th, 377 days. This is the female. Nobody can do that at all. Most important is the MSC. They are the most important. Team effort. Put together with mind doctors versus respiratory practitioners. That's problem. So take the baby from my hand to this level. I lost some hair, gained some weight, gained some gray hair. I got old, but the baby's getting big. She's running around very pre-discharge MRI of the brain was completely normal. We were blessed to understand to have an outcome like this. That doesn't happen that often. But put together our minds, have hope, and get the best outcomes. Nobody is interested just in survival. All of us are interested in survival without intact survival. So what can we do? Approach to a preterm baby already has changed over the last 40 years. In the 1970s, we had CPAP, continuous positive air compression. That's all we had. No surfactant, no steroids. Then, 1972, ligands used antenatal corticosteroids to accelerate blood pressure. That was 42 years ago. In the 1980s, post-natal surfactant therapy was initiated. And then in the 1990s, we got better about conventional ventilation. We started synchronized ventilation. We started high frequency ventilation. We thought they would be better. Unfortunately, in bronchopulmonary dysplasia. In the 2000s, maybe most important thing that we can do a preterm baby in the delivery room is stabilize the lung, establish the FRC, avoid giving big breaths. You're going to start lunging within the first minute or two if you're not careful. Take it easy, baby's not going to die. Put them on CPAP, if they need oxygen, titrate the oxygen. That's another talk. And then use insure or modified insure technique. I won't spend too much time because my other speaker will cover that. Two things that happen in perinatology and neonatology. Antenatal corticosteroids and postnatal surfactant therapy. Very nice commentary by Alan Joe. Look at the data. These are number of patients. This is 28-day mortality. If the mother gets antenatal steroids and the baby gets surfactant treatment, no baby dies. If the mother doesn't get antenatal steroids and no surfactant, 25% of the babies die. Significant reduction in mortality if you combine these two things. You cannot just treat only with antenatal steroids or only with surfactant. If you do that, yeah, you will reduce it from 25% to 18%. Or 25% to 50%. But you can make it down to 0% and improve the survival. If the mother got corticosteroids and the baby gets RDS, you use a factor to the baby, the best outcome. So he said, no other therapy for a pregnant woman and a preterm baby are of as much benefit as prenatal corticosteroids and postnatal surfactant for babies with RDS. Sometimes people say, or administration, or government says, you should eliminate steroids, you don't need surfactant. No, it doesn't eliminate RDS 100% of the time. You still have agent that requires surfactant. So these are the three major surfactants. Somebody tells you all surfactants are the same, then I can stop my talk here. They are not the same. There are major biochemical differences between the three commonly used surfactants. One is porcine surfactant called curosur, 4-actin alpha. Two bovine surfactants. One is minced bovine called Surventa, Iraqin. Third is cofactin or impostor, which is a Laval preparation. If you look at the compound phospholipids, which is the most important component of surfactant, is 76 milligrams per ml. Curosur, 25 milligrams per ml. Surventa, 35 milligrams per ml. The second most important component, disaturated phosphatidylcholine, is the most active phospholipid, disaturated phosphatidylcholine. 30 milligrams per ml. Curosur compared to 11 or 15.5, there is variability batch to batch. Surventa and 16 milligrams in first. Next important one is surfactant protein B. If a baby is born without surfactant protein B, the baby is dying. The only treatment for that condition is lung transplantation. Surfactant protein B is the most important surfactant protein for lower in the stage. Again, curosur happens to have highest amount of surfactant protein, 0.45 milligrams per ml. Surventa is quite variable, therefore they don't report in the package itself. Impostor contains 0.26 milligrams per ml of surfactant protein. What about status? If we compare one bovine surfactant versus another bovine surfactant, there are 3 studies that have been published, large studies, comparing Surventa versus impostor. Prophylaxis study. Prophylaxis study means babies are randomized before they are born, and then randomized to get Surventa or impostor within 15 minutes. That's prophylaxis. 10 to 15 minutes. Rescue means babies being certain criteria for surfactant therapy based on the authors of the study. Okay? They're intubated, most of the time the requirement is they're intubated and their FiO is more than 30% or an arterial alveolar PaO2 ratio. Arterial alveolar PaO2 ratio 0.2 or less. So they look at the primary outcomes. No difference between these two surfactants. Any of the studies. The primary outcome was how many babies require a second dose. No difference between these two. Secondary outcome, they showed that impostor effect is longer. In other words, these babies take longer time to meet the threshold for a second dose. No difference in the need for a third dose, that's the primary outcome. And then lung mechanics, lung compliance, small study, no difference between these two surfactants. And then largest 2 studies that were planned in 2005 and published were stopped early because it was taking much longer to complete the study. Therefore, both these prophylaxis trial and the rescue trial were stopped early. However, they enrolled 749 babies. Found no difference in DDE. And in this trial, original sample size 2018, they started the study after 1,364 babies, again showed no difference, primary outcome of DDE between these two surfactants. In other words, if you are using Surventa, stay with Surventa. Don't go and change the impostor. If you're using impostor, stay with impostor. Why don't train people unless they give you free? So cost, right? The randomized controlled trial is no different between these two bovine surfactants. They are the ones that compare large randomized controlled trial. Now let's go to the porcine surfactant and bovine surfactant. Before that, they looked at these 4 studies. They looked at the number of babies that require a second or more doses, somewhere around 50. The prophylaxis trial, rescue trial, about 70. In other words, if you wait longer, you lose surfactant, you lose some other benefits. You end up giving more and more doses. That's one of the controversies. Should I do prophylaxis? Should I do early rescue? Or should I do delayed rescue? I think the data supports early rescue therapy. Non-prophylaxis, non-delayed rescue. Here you can see, same surfactant, same type of babies, 70% of the time, babies require a second or third dose. But if they gave it early, 48%. So if you're going to give a baby surfactant for all, yes. Whatever criteria you use, follow them. Don't say, okay, I'm going to wait and see how the baby is. You're going to put more money into the baby and you don't get much benefits. So let's now compare 6 randomized controlled studies published, comparing porcine surfactant HeroSurf versus bovine surfactant surfactant. No studies comparing HeroSurf versus InfoSurf in the randomized controlled trial. Every single study showed from 1995 to 2011 that babies that were treated with randomized HeroSurf or 4-actin alpha had faster weaning of oxygen, more extubations, less days on mechanical ventilation, less PDA, less bronchopulmonary dysplasia, and less mortality in babies less than 30 weeks. Very quickly I'm going to show the data from these 6 studies. In the first study by Spear, he showed that babies randomized to HeroSurf, they were able to wean faster the FiO2, peak expiratory pressure, and mean airway pressure were lower up to 24 hours. After that, they were same. That's the primary outcome. Is there a difference in response to the surfactant therapy? Acute. They showed, yes, you can wean the babies faster if the babies get HeroSurf compared to surfactant. Now let's study again, we look at nearly 293 babies. So we compare 100 milligrams of Surventa, 100 milligrams of HeroSurf for the first dose, or 200 milligrams. Both 100 milligrams or 200 milligrams of HeroSurf, you can wean faster compared to 100 milligrams of Surventa. From milligram to milligram, still a better surfactant based on randomized controlled trial findings. Primary outcome, okay, faster weaning, both 100 and 200 milligram dose. What about the dosing requirements? Second dose, again, redosing criteria are the same. They're also like the opposite. Only 27% of the time, babies that were given a 200 milligram dose, but these babies are very sick. The baseline FiO2 was 65%. This was done in 2000. Started in 2000. The antenatal corticosteroid use was very low in the US, 75, 80 deaths at that time. These are sicker babies. So even then, 47% of the time, babies require a second dose. If you gave 200 milligram dose, compared to 41, 100 of HeroSurf, and 49 use Surventa. Overall, 36% of the time, babies required a second, third, or fourth dose, compared to 68% of babies randomized to Surventa. Clearly, the need for additional doses were less. What about the outcomes? They're very similar. We look at pneumothorax, hepatitis, pulmonary hemorrhage, necrobasal encephalitis, intraventricular hemorrhage, high-frequency ventilation as a rescue, bronchopulmonary dysplasia, they were all similar. Surprisingly, we found the lower mortality in the group of babies randomized to 200. And the first time, we saw a statistically significant decrease in mortality in babies who were given 200 milligram dose compared to 100. So based on this, there was a meta-analysis published in 2005 combining a small trial by Spear in 1995 and 10 years later of a study, and they showed neonatal mortality odds ratio 0.35, confidence interval is 1, but still statistically significant decrease in mortality. Third study from Chicago, Mayo. They put in a numerical arterial catheter, continuously monitored the PaO2, and then decreased the FiO2. In babies randomized to Curosip or surrender, and they showed that up to 48 hours, babies given Curosip required less FiO2 compared to babies treated with surrender. Similar to what the previous studies have shown. We also looked at the mean dosing, much lower, 1.2 versus 1.7, and the mean volume was also much lower, 2.8 ml compared to 6.9 ml, which we know because Curosip is the most concentrated surfactant compared to surrender or infrastructure. Alan Fuji from Boston published this paper in 2010, looking at, again, this is up to 72 hours. They show in a small study that babies randomized to Curosip or 4-actin alpha required less FiO2. Mean airway pressure times FiO2 is also lower than Curosip babies compared to surrender. And more babies, they looked at babies extubated at 24, 48, and 70 hours. So more babies were extubated at 48 to 70 hours in babies randomized to Curosip compared to surrender babies. That would mean more extubations. Interestingly, we also found other benefits. For example, number of babies that develop air-leak syndrome, 0, compared to 15% in the surrender group. Patent ductus arteriosus diagnosed by echocardiography was significantly low, 32% compared to 76% in the surrender group. And patent ductus arteriosus required ligation is also low, 16% versus 48%. Then they looked at EPD, ROP, intraventricular hemorrhage, and you see noted. Again, mortality was low, not statistically significant, 8% versus 19%. That's more than 50% less mortality, right? But small study, therefore, it was not statistically significant. Lastly, a study from Turkey in 2011 comparing Curosip versus surrender, and they looked at on day 1, day 3, and day 5. Up to 5 days, if the baby got Curosip first dose, they required statistically lower FiO2 compared to surrender babies. And other outcomes they reported in the study, number of babies that were extubated within the first 70 hours was significantly higher, 81% compared to 56%. They looked at number of babies requiring 2 or more doses, it's also lower, 12% versus 31%. And BPD-free survival is also much higher, 78.7 Curosip babies compared to surrender, 58. And mortality again half, 20% versus 10%, but sample size is small, 126 babies, therefore it was not statistically significant. If you look at all the 8 studies comparing bovine versus porcine or bovine versus bovine, no difference when you compare one bovine versus another bovine surfactant, like surrender versus infrastructure. However, the studies that are comparing Curosip versus surrender, Curosip surrender, Curosip surrender, every single study, the dosing requirements were less. Therefore, it is cost-effective. It may be more expensive in the beginning, but in the long run, it will be cost-effective. So there is a study from London, meta-analysis published,